So the imaging tools that we have in our hands are X-ray, ultrasound, nuclear medicine, magnetic resonance imaging, and CT or computed tomography. Please get settled now. Okay, so X-rays. Do you think there's a role of X-ray?
Yes.
X-ray for the brain?
Yes?
I don't think so.
Okay, he's right. There's no role of X-ray in the brain because the brain tissue is not seen on X-rays. Yes, there is a role in X-rays, but obviously with X-rays still you will need to know details of the brain, what is underlying. Okay? If you have a skull fracture, so what? Still you would like to see whether the skull fracture has resulted in trauma to the brain underlying. So you would do still a CT scan. So the X-rays are now hardly done for skulls. To see what is going on in the brain, you need to do an MR or a CT. Yes. Sorry? I can't hear you. To see what? Why do you need to do an invasive procedure when you have a non-invasive CT or an MR which is done within 5 seconds? Obviously, it makes sense. Okay, ultrasound. Ultrasound again has a limited role. In children, when the brain is not, the skull is not calcified and it's still membranous, you can use the fontanelle and you can use the probe and you can sort of image the brain in a child or in a neonate. But in adults, when you have the skull which is calcified, you cannot see the brain through the bone. So obviously, it has a limited role. Nuclear medicine is still an imaging modality in which you give a tracer through the blood, like you do when you give IV contrast. In like that, you studied contrast. I already know that. Like iodine and gadolinium. Similarly, you have a radio tracer which is injected, and then you see the metabolic activity in the brain. So like in Alzheimer's disease and some other diseases where you would see the activity inside the brain, you would use nuclear medicine. So it's a sort of experimental tool in those cases where you are trying to see the degeneration or the metabolic activity in the brain. The imaging modality, by far the majority of cases that you rely on are the MR and the CT. Now, we have to differentiate between CT and MR. Which one do you think is the more important one in an ER setting?
CT.
Why?
It's faster. It's faster.
It is faster. Good. One answer is faster. And then what is the other reason?
It visualizes strokes better.
He's right. You need to, in an ER setting, you need to differentiate what type of stroke it is. Is it an hemorrhagic stroke or is it an infarct? Okay? So, because the treatment pattern is different in both. In an infarct, you would anticoagulate. In a hemorrhagic stroke, you would not give anticoagulant. So this is rapidly determined when you ask for a CT through an ER. It is done within 5 or 10 seconds, and then you can plan accordingly. Whereas MR takes 15 to 20 minutes to complete the study, and it's mostly done in those cases where you need to know more in detail, when you're not suspecting hemorrhage, or you are trying, the case is planned like a tumor or an infection where you already have a scanning before and you're sort of following it up. So MR is more soft tissue details that you need. CT is where you just want to rule out hemorrhage so that you can put him on anticoagulants. Clear on this? Okay, so since you have not studied CT and MR, so I have to give you a little more details what these CT and MR mean. In CT, you are using radiation. So you're giving X-rays. It is an X-ray machine, like you have this tube there, which emits the X-rays, they pass through the patient, and then there are these detectors which detect the X-rays that have come through this tube, past the patient, and then they are reflected on the detectors. So now the concept here is the X-rays that pass through the patient, if they are allowed to pass easily, they would have a different image, and if they pass after being hindered or if they are stopped in between, like just imagine the brain tissue is soft tissue, so the X-rays would be easily passing through the soft tissue. Whereas the skull, which is the bone, is compact tissue. It is tightly, the atoms are tightly bound, so it is compact bone. So the X-rays would not be easily passing through the brain, the skull bone. So the appearance on CT for bone would be different from soft tissues. Now the CT has this ability to assign Hounsfield units that are the different gray scales. Now if you see this brain, this is black hair, this is gray hair. So what do you think the black area is?
Ventricles.
The ventricles, good. So these are CSF containing ventricles which are black. This is the gray tissue which has white matter and the gray matter. And this white is the bone, which is the skull bone. So you see black, gray and white. So different shades of gray. So if you measure this, the Hounsfield units here would be say 0 or negative. If you measure the Hounsfield units here, it will be in 70s, say 70, 80, it will come something like this. If you measure the Hounsfield unit here, it will be in thousands or hundreds. So you see every tissue has a different Hounsfield unit. Now the beauty of CT is, unlike the X-rays, it can also differentiate between the soft tissues. So this is why we use it in the ER setting. We can differentiate between the hemorrhage and the soft tissues. Now what happens here is the X-rays that are passing through the skull, the X-rays that are, majority of the X-rays that are reaching, like if you have fluids, majority would be reaching the detector at that point. If they are passing through the brain, some would be passing, some would be stopped. If it is bone, majority would be stopped and some would still reach the detector. So the detectors that are around the brain would be able to detect different gray scales. So the machine automatically, it is connected to the computer and the computer automatically generates these or gives these scales of gray different shades. So you have black shade, you have gray shade, you have white shade. So these shades reflect different tissues. Okay? If you don't understand, don't worry. We'll see these examples and you'll understand how it works. Now, a little bit about MR. It doesn't have X-rays. So obviously we are talking about a magnet. Okay? Magnetic resonance imaging means a magnet. So there's no X-ray involved. So there's no radiation. So there's no harm in this, getting an MR done. Now, if you know the concept of MR, just because you haven't read about MR, so I'll just give you a layman's example or layman's explanation how an MR works. Actually, the human body is 2/3 water. Okay, the water is H2O. The H2 is protons. Okay, this machine has a giant magnet. You can call it 1,000 times stronger than a routine magnet that you know of. It is measured in Teslas. So we have different strength of this magnet, say 1.5 to 3 or 5 Teslas. Now when you put a human body inside a magnet, that is this magnet, the magnet has a magnetic field around it when you turn it on. The human body, once it goes in, the water content has H2 protons. These H2 protons or these protons act as small magnets. When they go inside the magnet, these small magnets align inside the magnetic field. Okay? So they all align. These all protons align inside the magnetic field under the influence of the magnetic field of this big huge magnet. Next step is give a radio frequency pulse or radio frequency current inside this magnet. Now what this will do is these protons will be they would be flipped from their spinning. So instead of aligned straight like inside the magnet, they would be flipped in another direction because of this radio frequency current that you gave it from outside. This radio frequency current itself has a magnetic field. So these protons align now according to that field. Now you switch off this field that you gave. The protons again try to return back to their original alignment. Now remember, these protons that are inside the human body are lying inside different tissues. Some tissues return back slowly, some return back fast. So the returning back emits signal. This signal is captured and this is transformed into images by the computer. Okay? Just remember, these protons are lying inside this big huge magnet. You give a current from outside, they start aligning according to this external source current which has a magnetic field now. You turn off the field, they try to return back to that same strength or same field that was initially there. In returning back, some protons would return slowly, some would fast, depending on where they are located inside the body. So different tissues will react differently. Water would react differently, soft tissues will react differently, protons in the bone would react differently. That is why you have different signals emitted at different stages. So these are picked up again, and from that the images are transformed. So this was a simple layman explanation. Obviously there is a lot of physics involved in this. And from this, remember, there are two types of sequences that you should remember, T1 and T2. In MR, there are two sequences, T1 and T2. All other sequences that you know of, like flare, like proton density, like inversion recovery, like diffusion weighted images, all these are T2 weighted images. Actually, the T1 weighted image is for anatomy.
For what?
Anatomy. Anatomy, okay?
Yes.
It is for the anatomy. T2 weighted image is for pathology. So the pathology is better picked up on T2. The anatomy is better seen on T1. Clear? Remember, the sequences that you will hear of in your later life are all derivatives of T2. So there is no sequence that comes from T1. All sequences are from T2. Clear? We'll come to this. Okay. Now there is these three-dimensional, we talk about three-dimensional imaging in MR. So it gives you actually a three-dimensional view. Now what we are doing here is, if you focus on this image, if you chop in the center, you would have right and left half, so it will be a sagittal view. If you chop me in through this horizontal, so there will be an upper part and a lower part, so this will be axial view. And if you chop me like this in the coronal section, so there will be anterior half and posterior half, so it will be coronal. So this is how you get the three-dimensional views on MR. We talked about this. This is the gantry. In a CT, you have a table which goes in, and you have X-ray machine and the detectors which are continuously revolving around the patient. Now the contrast that you give, you know, this is iodine. Why? Because you need to have high density. Iodine gives you high density. Like the bone has high density, iodine also has a high density. It is a metal. So when you inject contrast, it gives you enhancement. When you do a CT after contrast, give injection, it will enhance. The area would become bright because obviously it is a metal. Iodine is a metal. Now the areas like tumors, like infection, have more vascularity. So the contrast would accumulate there, and it helps us in differentiating different tumors for an infection. So the contrast is given in infections, tumors, epilepsy. It is not required in trauma because all we are looking for is fractures or brain hemorrhage. In trophy, obviously it makes sense. Why do you need contrast? You're just looking at the volume of the brain. Stroke patients, you're looking at infarct or hemorrhage. You don't need to give contrast. Okay? And obviously renal function, if you have impaired renal function, you cannot inject contrast.
So this is only for CT, right?
This is what?
Only for CT, not MRI.
Yes, we are talking about iodine at the moment. Contrast media, this also holds for, by the way, in infection and tumors, it also holds for the MR. But obviously the contrast is different. In MR, the contrast is gadolinium.
Why is contrast used for epilepsy?
Why is contrast useful for?
For the epilepsy.
Epilepsy can have different reasons for epilepsy. Epilepsy can be because of tumors, can be because of infections. So obviously it has a role. Children and uncooperative patients, you need to sedate them, and you need to have the patient 4 to 6 hours fasting if you are giving contrast. Why? Vomiting, yes. Because you stab the patients on the table, and when they vomit, obviously they can aspirate. Okay, so you need to have a reference line so that every time you scan the brain, you start from the same level. So we are sometimes comparing the scans. If you do CT today, you might need another CT after a month, and you need to compare. So what we have is a standard line, orbito-meatal line, from the orbit to the meatus. So you have a line here, you scan parallel to this. So you from here to here, you start from here to here. So you go up parallel to this line. Here, you see this is the orbito-meatal line, and you scan going upwards. So if you scan brain at this level, this is what you get. This is the orbit and this is the meatus. So most of the base of the skull is white because
Bone.
it is bone. Base of the skull is bone. That is why majority of it is white. As you go up, you start seeing the brain stem, And if you go up, this is how the CT looks like. From top to bottom, this is from top to bottom. Okay? So different structures differently. Now remember this, the CSF is black, the grey structures are grey, that is the brain tissue, and the white structure is the bone, which is dense, compact tissue. So it is white on CT. Okay? So this is from top to bottom. You start seeing these sulci and these gyri. Okay? If you try to differentiate between the cortex and the white matter, it is difficult to see. We can see this much better on MR. I'll show you how it looks like. If you go down, you start seeing the ventricles. These are the lateral ventricles, the thalami, the external capsule, pons, this cerebellum, temporal lobes. You start seeing the base of the frontal lobe. These are the optic nerves, and these TD eyes, globes. Okay, the sinuses, these mastoid hair cells. Okay, so a lot of structures can be seen on MR and CT. Now this is CT or MR?
MRI.
Why is it MR?
We can see that
We can visualize soft tissue.
Okay,
different planes.
different planes, good. Okay, what is this white structure?
Skull.
So what skull is, if it is white, it should be CT.
Sometimes. Can play with
Okay.
computer.
What comes, okay, skull bone, what is above the skull bone? Skin. Skin has fat. Skin has subcutaneous fat. So this is fat. That is why it is white. The bone is black here. You see, this is the bone. Now you would ask me, what is this white inside the bone? Bone marrow, which is again fat. So the outer skull table and the inner skull table, and there is marrow inside. So that is why you have this bright signal here. So you see how fine details you are able to pick up on MR. You are not able to see this on CT. All on CT that you see is white. Now these structures in the midline, this is the corpus callosum, this is the pons, this is the cerebellum, this is the fourth ventricle. So you've cut the brain at the level of the fourth ventricle, this is the pons, this is cerebellum. So you have a three-dimensional view on MR. Much better view on MR. This is MR. Now let's see which one is the MR and which one is the CT.
Right MRI.
Right CT, left.
Okay, this one is the MR, as you said, this bone is black, here the bone is white. So you see, the details are much better on MR. When you see it on CT.
Doctor.
Yes?
Back.
Yeah?
Is this, these spaces, are they because of contrast material or because it's a bone?
Okay, you're talking about this.
Yeah, this and in the middle.
Okay, this one is the petrous bone. It's a bone. It's petrous part of the temporal bone. Okay, so you have mastoid hair cells inside the petrous part of the temporal bone. This is the petrous part and this is the mastoid part. This is the greater wing of the sphenoid. So these are all bones. That is why it is white. It's CT, bones are white. Okay? The CSF here, this is the fourth ventricle. Okay, so this is CT. I have left an atlas here with labeling of the brain both in CT and MR. The ones who are interested to see how the different structures, because obviously there are thousands of structures in the brain, which you can see on both MR and CT. You can go through these atlases. Just remember the basic concepts that how to differentiate between MR and CT. Rest are all there labeled in the atlas for you. It's around 13 or 14 page atlas. It's there on your desktop. Take that home. Go through these images. The images that you remember from your anatomy, knowledge, you will be able to see them all on MR. I'll show you the major the important structures that you can identify. Now, this is quadrigeminal area. The CSF behind is cistern, which is the CSF containing area. Cistern, we call it cistern. So there are various CSF containing areas in the brain are sometimes labeled according to the area that they belong to. Like this is in relation to the quadrigeminal plate, so it is called as quadrigeminal cistern. There are a few other cisterns like ambient cistern, like supracellular cisterns. So different cisterns where you have CSF and they are labeled according to the adjacent structures where they are located. Now you know this from your anatomy. What is this?
skull.
These are the ventricular